النهارده هتكلم عن موضوع شيق the common finding اللي هو pulmonary hypertension. Perioperative management of pulmonary hypertension. كمقدمة قبل ندخل على preparation لعيان الانستيزيا والانستيزيا بأنواعها المختلفة والريسك وخلافه، هنتكلم عن مقدمة عن تعريف pulmonary hypertension medications وdiagnosis وخلافه. أول حاجة definition of pulmonary hypertension. It's a syndrome with elevated pulmonary artery pressure. The mean pulmonary artery pressure is more than 25 mmHg at rest. It's associated with reduced nitric oxide and prostacyclin synthesis, as well as increased thromboxane production. Histologically, or histological features, there is medial thickening and intimal fibrosis. Classification. We have 5 different categories of pulmonary hypertension. Number 1, isolated pulmonary arterial hypertension. تاني, associated with diseases of the respiratory system and hypoxia. زي في حالات COPD, chronic obstructive pulmonary disease, obstructive sleep apnea syndrome. The third type, pulmonary venous hypertension in mitral valve diseases and chronic left ventricular dysfunction. Fourth, chronic pulmonary embolism. And finally, number 5, direct obstruction of the pulmonary vasculature, inflammatory pulmonary capillary hemangiomatosis, for example. Pathophysiology. The major concern is the development of right-sided heart failure, either acute or chronic. In chronic pulmonary hypertension, right ventricular hypertrophy is followed by dilatation and failure with the following events. Reduced right ventricular stroke volume, and this is the preload of the left ventricle, so the net result is hypotension. With increase in the pressure in the right ventricle, there is intraventricular shifts of the left ventricle decreasing its output to mean what's called interseptal deviation. The septum is deviated from the right side, crouched the left ventricle with subsequent reduction of the left ventricular output. Third, reduced right ventricular coronary blood flow. And finally, in patients with patent foramen ovale, there will be right to left shunt in these patients with subsequent hypoxia. كنا عارفين patent foramen ovale ده موجود بين right and left atrium. ده كان اسمه الكرونيك changes. طب ايه acute changes؟ Because the right ventricle is designed for a low pressure system, an acute increase in the pulmonary pressure often results in rapid ventricular failure, as in acute pulmonary embolism and acute severe mitral regurg. Prognosis. Pulmonary hypertension is a progressive disease, and deterioration over months to years occur. ايه العلاج اللي بياخده يا جماعه دول؟ What is the medical management? Treatment of right side heart failure by diuretics, digoxin, salt and fluid restriction, calcium channel blockers, warfarin, prostacyclins and prostacyclin analog, endothelin antagonists, phosphodiesterase inhibitors, namely sildenafil or Viagra. طبعا كل الحاجات دي to reduce the pulmonary hypertension. Surgical risk. High risk. Death occurs in 4 to 24% depending on the severity and of course of the surgical procedure. Hemodynamic spiral. ايه الهيمودynamic changes او deterioration او السيركل اللي بتحصل في العينين دول؟ لو حصل right side heart failure ده بالطبع بيؤدي الى decreased pulmonary blood flow التي تؤدي بالتبعية إلى hypoxia and increase in pulmonary vascular resistance. ده يمثل strain on right ventricle of course فيؤدي بالتبعية إلى decrease stroke volume of the right ventricle اللي هو في النهاية بينتهي عند left ventricle ففي النهاية عندي decrease left ventricle output and subsequent decrease in coronary blood flow to both ventricles. The already failed right ventricle may not be able to recover arrest. عشان كده الانستالجيست يبقى حاطط في مخه هذه القصه وما يطورش الموضوع ويضع في ذهنه زي ما بنقول بعد شويه ازاي ما يؤديش الى further increase in pulmonary vascular resistance بمعنى الاسيدوزس والهايبوكارب زي ما هنقول ومحافظه على contractility of the ventricle بقدر الامكان لابد من depressant drugs بحافظ على البريلود by assuming euvolemia يبعد عن الاريثميا عشان يحافظ على الاوتبوت كامل زي ما هنقول بعد شويه لأن لو حصل arrest it is very difficult to recover in these patients. Pre-op evaluation. The goal is to determine if the patient suffers from pulmonary hypertension, has right ventricular failure or not. This is important. Of course, respiratory failure and right ventricular failure are the common complications. Pre-op evaluation. These are the items of pre-op evaluation: clinical findings, etiology if possible, echo, cardiography, cardiac catheterization, continue the pulmonary hypertension medications, complete blood count, coagulation panel, metabolic panel of blood gas, and ECG for signs of ischemia or right-sided ventricular strain. هنشوف واحدة واحدة فيهم كده بسرعة من ال pre-op evaluation. First, clinical findings. Signs are vague. Dyspnea with exertion, progress to dyspnea at rest, fatigue and syncope. نؤكد هنا ان history of syncope is an extremely poor sign. The patient may have symptoms of low cardiac output and metabolic acidosis along with hypoxia, syncope, and evidence of right ventricular failures indicate severe disease state. Echocardiography or echo, we see the valvular structure, the size, the function of both ventricles, and the presence of intracardiac shunts. However, measurement of mean pulmonary arterial pressure is underestimated, and cardiac catheterization remains to be the gold standard of its measurement. زي ما هنيجي بعد كده. Cardiac catheterization is the gold standard for mean pulmonary arterial pressure measurement. فائدة إضافية تانية during cardiac catheterization, pulmonary vascular reactivity can be determined at catheterization to test responsiveness to vasodilators. Pre-op evaluation. تاني كلمة عن medications. What about the pulmonary hypertension medications? Of course, أغلب drugs should be continued the day of surgery. Calcium channel blockers, digoxin, diuretics, prostaglandin infusion, and sildenafil. Patients are often taking comadine, and they should be transmitted to low molecular weight heparin prior to surgery زي ما احنا عارفين. What are the anesthetic and hemodynamic goals of pulmonary hypertension؟ لما نسأل حد ونقول له what are the anesthetic goals for any disease، ما يقعدش يقول لي ادي اعمل اندكشن بالبرفان وادي مصر لاكسن، مش ده المطلوب. المطلوب الجولز، ازاي احافظ على هذا العيان. جنرال برنسبلز، ازاي احافظ على الكارديك اوتبوت، ازاي احافظ على الهايبرتنشن، وهكذا. زي ما نقول كده، زي ما جاي قدامي، ما اقعدش اقول اسماء دراجز. لما اقول لك تكنيكس بتحكي لي في الدراجز بعدين، لكن ده the goals. So the goals in anesthetizing these patients as follows: avoid elevations of pulmonary vascular resistance. طبعا طبيعي by preventing hypoxemia, preventing acidosis, hypercapnia, and pain. So provide supplemental oxygen at all times. Number 2, maintain systemic vascular resistance, because decreased systemic vascular resistance dramatically reduces cardiac output due to fixed pulmonary vascular resistance. Avoid myocardial depressants and maintain myocardial contractility. طبعا ده avoid inhalation زي ما هنقول بعدين as possible. Maintain preload، ما ينفعش عندي بقى ايوفوليميك، سوري يبقى هايبوفوليميك، لازم عندي ايوفوليميك واخد محلول كفايه. Maintain sinus rhythm. دي general principles or anesthetic goals in anesthetizing a patient with pulmonary hypertension. Type anesthetics طبعا لو الظروف تسمح، سواء العمليه او العيان، regional is the best. Second, peripheral nerve block and epidural rather than spinal. In moderate to severe pulmonary hypertension, spinal anesthesia is used very cautiously because abrupt alteration in systemic vascular resistance and preload is very risky in these patients. Be cautious. For patient taking sildenafil or Viagra, avoid nitroglycerin and nepriles, which can cause severe hypotension. Monitoring. In addition to the standard monitoring، ممكن تستخدم arterial lines. CFE, cautious during placement to avoid arrhythmias. If arrhythmias develop cardioversion, avoid rapid cardiovascular collapse. The use of pulmonary articaster, although it's obsolete or not used, very difficult to be placed in these patients and contraindicate an Eisenmenger syndrome. Finally, transesophageal echocardiography. General anesthesia. There is high resting sympathetic tone and resultant deficiency of catecholamine levels. Can result in exaggerated hemodynamic compromise following induction. So, induction should be titrated slowly to the effect. استخدم the lowest dose and injected slowly as possible. Sedation should be supplemented with oxygen and should be minimized as possible preoperatively to avoid the development of hypoxia and hypercarbia. طبعا هم عارفين هم الاثنين دول هيزودوا systemic vascular resistance and put strain on the right ventricle, which may fail. زي ما قلنا الاندكشن يبقى slowly slow titration of opioids. opioid معروفة اللي ليها hemodynamic stability, followed by induction agent as intermediate to limit hemodynamic changes. طبعا ما فيش intermediate مش عندنا، استخدم ديبريفان بس ادي دوز small dose and inject it slowly. Lidocaine can be used 1 ml per kg to blunt the hemodynamic effects of intubation. For maintenance anesthesia, combination of inhalation agents as minimal as possible with opioids and muscle relaxants. Benzodiazepines can be considered, being had a little depression on the hemodynamics. Fluid management, as possible, maintain euvolemia. Trans-echocardiography, and maybe pulmonary echocasters measurement should guide fluid management, which are not to overwhelm the right ventricular function. I mean care not to overwhelm right ventricular function. Hemodynamic measurements. Avoid euvolemia. Inotrope therapy should be considered if hypotension persists, though the patient is euvolemic. You can use dobutamine or milrinone, inhaled nitric oxide, inhaled prostacyclin, phenylphrin, norepinephrine, vasopressin. They have variable response in these patients, but may be needed in the setting of persistent systemic hypotension. Ventilator management. Avoidance of hypoxia and hypercapnia is critical in these patients, as we said before, but should be balanced by avoiding lung hyperventilation, hyperinflation. Large alteration in lung volumes by positive pressure ventilation, along with either inadequate or excessive PEEP, can dramatically alter pulmonary vascular resistance in pulmonary hypertensive patients. So, the use of low tidal volume ventilation with low PEEP is the ideal strategy, adjusting respiratory rate to avoid hypercarbia. Post-op management. Of course, this patient should be monitored in the ICU because there is risk of sudden death. This patient may benefit from epidural analgesia for post-operative pain. And finally, the patient should be put back to their usual oral anticoagulant. Thank you.